and have been, and now I have follow-up of 10 years and 15 years, those who have been operated earlier. So that that whole concept, which is so deeply rooted in mind, my own resident telling to patients, they come after at the age of 15 years.
Even I'm guilty of that. That's what
this has been happening. Yes.
No, but then do you have to counsel the parents that he may require a revision after the age of 16?
Yeah, yes. Obviously, you have to tell them.
You have to
but
tell
you have to tell them there's a long period between 7 years and 8 years or 15 years. You can't let your child suffer for these many years.
Okay, right. The same question to Dr. Ashish is for pinaplasty or treating microtia, what age would you consider?
So, like I said, the age is not so critical. Age is important in terms of by 6, 7 or 8, the normal ear is almost 90% of the adult size. So
probably it's at 10 or 11?
So yes, so 10 or 11 is where you sort of, because that's the chest circumference is important.
Chest circumference.
So 60 centimeters chest circumference, let's consider 10 years as age.
Okay.
For simplicity.
10 years at age. Fine.
And when I say 60 centimeters, not the obese chubby child. We want the cartilage to be
the cartilage to be
not
nice and soft and pliable.
Not like a thick layer of fat that is 60.
But then when you operate patients at a higher age, do you find molding these cartilages may be ossified, so creating a pinna may be difficult?
Theoretically it seems so, but in experience not sure. Even a 20-year-old has a grossly ossified, and 18-year-old may still have a beautiful cartilage. Because we almost do CT scan test, we anticipate the ossification and decide which is right or left side, which is a better one, less ossified.
Fine. Dr. Seema Sheikh, we often find chest physicians saying that there is no role for surgery. I mean, in OSA. I mean, it's like probably they say that if you have a hammer, everything looks like a nail, in front. So, what would be your opinion on this?
That's exactly the concept that we are changing now. We need to understand that we also have a major role where it comes to removing the obstructions. But we have to put it across to them that we are not entering the entire field of sleep apnea. We are entering the obstructive element part of it.
Okay.
Their main scare was, and they were the major resistors for me when I got into this field, because they thought that we are entering into a field and going to probably take away the CPAP from them. So now over the years, even presenting on their platforms, when you actually tell them that, listen, we have a definitive role to play in evaluation, because you cannot see the upper airway, first thing. For example, if the dice that I showed with a epiglottic collapse,
right.
Now if that patient is given a CPAP, he's going to suffocate. So they need to know that we have a definitive role in evaluating where the obstructions are, and then we go ahead scientifically and evidence-based in trying to remove it. So
to add even for the pulmonologist, the same analogy applies. That for every hammer, everything looks a nail.
So
for them, for everything, it's a CPAP fitting thing. It cannot be.
So they don't have another option.
So CMAP is not against CPAP. That's
so you mean the chest physicians will lose their sleep now, I mean. Yeah, now the question is to Dr. Deepak. This question is from Payal Chitran Shea. What is the basic difference between BPPV and cupidolithiasis?
My talk has not been communicative because cupidolithiasis is a variant of BPPV itself. What we are talking was canalolithiasis and cupidolithiasis. So when you miss the typical sine curve when you put the patient on the Dix Hallpike and you get the vertigo instantaneously or the nystagmus instantaneously, a little more prolonged and severe, you realize it is cupidolithiasis. Second, patients in whom you do an Epplees and they come back to you after a week after week, again you get a suspicion it is cupidolithiasis. So they are not different. It is another variant. So both posterior canal as well as lateral canal, the common one which you see is a canalolithiasis. The refractory or the resistant ones are cupidolithiasis.
Just to quote, because we are talking about Dr. Sudhir Kothari from Pune. I mean, I have seen some of his patients, probably I think he advises brand Daroff maneuver for most of them. So what do you feel? I mean, because...
Personally, I feel vertigo is a complete subspecialty. Just like how we have realized that the ENT surgeons are better off doing rhinoplasties than the plastics. Similarly, now that you have realized 92% are peripheral vertigos, I think the ENTs are much better in treating a vertigo case overall than the neurologists. And I gave you the example that despite having 200 odd neurologists in Bangalore, we had to send this one patient to Pune, simply because they are also busy treating epilepsy, stroke and other things. So brand thereof is like you are trying to give a blanket coverage to everybody.
Yeah.
You do advise it, but for that subset, you don't do it to everybody.
Okay, man.
It's like the ENT surgeons prescribing both sinerizine and beta-histine, and both have the same action for vertigo, thinking that you're going to cover. Advising brand thereof to most of them is like I call as the GP drugs, which you get where there's norfloxacin, tinidazole, added with omeprazole and lactobacillus in the same tablet.
Yeah, something the masala drugs.
Yes.
I mean, okay. To Dr. Baser, this question is from B.K. Sinha from Ranchi. How do you minimize the risk of CSF rhinorrhea during a septoplasty?
Yes, interesting question. See, when you are exposing the septum, so do not go too close when you are doing the ethmoids, and do not use that lux forceps to break it. Rather than make a clean cut with a scissor or osteotome, because when you are breaking it out, you don't know where the fracture line will go. If you are cutting under vision and you are keeping up some distance from these things, you are safe. And another thing is, while doing osteotomies, do not, the medial canthal line is your Lakshman Rekha. So do not go above the medial canthus. You will not enter into the bronchiolite.
Dr. Ashish.
Can I ask him a
Yes,
question?
sir. Yeah, please.
Are there any, like you said, use the cartilage or use the ethmoid bone? Are there any titanium implants which are little easier to just quickly fit in?
Yes, the titanium implant, again, that probably they should invite me for a sleep apnea talk. The titanium implant in the nose. The titanium implants are not used in the septum, but titanium implants are used for alar valve collapse. And there is a guy in Switzerland, just my friend of mine, just slipping his name, and using a lot of titanium plates. And the Strauss makes a special titanium implant for alar collapse, because like a 80-year-old patient, you don't want him to go for a formal septorhinoplasty or an expander grafts. But putting a titanium plate helps in preventing the collapse, and that's a wonderful thing, can done in local anesthesia in few minutes.
And the body tolerates it?
Yes, I have, it works well. Very thin plate of titanium, and I have used in, the implant is expensive, but we are using this simple titanium plates which our magnificent surgeon does, and it works well.
Very well, thank you.
Yeah, now to Dr. Seemab. Dr. Ramesh has asked a question. What are the common reasons for failure in OSA surgery?
I would start off by saying you probably need to be very, very strict in your evaluation. I would always re-introspect myself, where did I go wrong? So maybe your selection of patient and the procedure for that particular palate or nose or whatever you did is probably what needs to be re-looked into.
Precisely.
That is the first thing that you must think of when you really look into a failure, without thinking that probably the procedure failed. The procedure would fail if it was probably improperly selected. Barring that, I mean, failures would be so many things. It's a dynamic process. So you do the best of things, patient picks up weight, 5-10 kilos, everything is going to fail. There are places where sutures would probably give away, fibrosis may not hold for that long. So whenever you are doing reconstructive work, these could be causing it. Excisional work, obviously the thing is not going to come back unless there's weight gain. So these are the probable causes, but I would always, if I get a failure patient, first check what exactly probably was not done correctly.
Okay. Yeah, Dr. Deepak, this is a question from Mahesh Kumar. What is the diuretic of choice, dose and duration, I mean in menias?
I use a tablet called lazilactone. I'm sorry, I don't know the composition exactly, but what I do know is it is potassium sparing. You need not add a pot chlor to it, and you give it for a month or two. Believe me, the attacks like something like 8 to 10 times in a month, where they were vomiting, and we would give them gentamicin, and then the attacks would cease, but the fellow would go into an ataxia. All that is not there, and these have virtually no side effects. You can give it for a long period of time, and they are so grateful. The attacks have totally stopped, and if you can cut down on the attacks, on the flip side, the intensity of tinnitus comes down a little bit over a period of time, and they are very grateful.
Can I add to this?
Please.
I do something called as a glycerol test. I used to earlier do a proper audiometric test, and now it works so well that I actually give it away to the patient.
It's excellent.
And 3 days the patient takes it. If they are great with it, then I put them on.
Even the audiometry shows that much improvement.
Yes.
Yeah.
And that diagnoses the the meaniers in which the endolymphatic eye drops lies.
Correct.
Probably even these diuretics work well only on
That's what I said. So that's the way I select.
and sometimes your MRI and CT may not pick it up as well.
So
You do a good MRI to pick the same thing. Sometimes you do pick up a dilated sac and duct. Sometimes you don't. But definitely a trial of lazilactone for a week.
Lazilactone. Great. I mean, so that means glycerol test would not only be a diagnostic test, it would be a therapeutic one also. I mean,
For 3
so
days
I
now.
mean,
Yeah.
that's perfect actually. So the one minute. Next question again to Dr. Baser. What are expandable grafts? From Mangalore, you have Dr. Bhaskar asking this.
Expander graft, as the name suggests, they expand something. What is that? It is the internal nasal wall. And where is the internal nasal wall? It is between the end of the septum and the end of the upper lateral cartilage. So you are putting this graft in between the upper lateral cartilage and the septum, so that increases the cross-sectional area of the nasal wall. And this is usually it has to be some rigidity. So septum is the best, the lower part of the septum which is strong. Best for expander grafts. If you do not have it, then maybe a rib cartilage or a concha. Concum is not that ideal, but it can be used.
Dr. Ashish, I mean, since you said we use the 6th, 7th, 8th, ribs,
Cartilage.
I mean, as an ENT, we are a little scared to go beyond the ear, nose and throat, or beyond head and neck, I mean. So, how would people get trained onto that actually?
So, no, just by actually doing. So, earlier my first 20 or 30 cases I used to call a general surgeon and do it. Then my earlier teacher, she saw me do this. She came to our clinic. She says, no, you have to learn to harvest it yourself, because while you are harvesting, the cartilage speaks to you a lot. It tells you what modifications when you cut and other things. So, I mean, it is just a matter of doing it.
Fine.
So, the only surgical tip there is you preserve the perichondrium on the undersurface. That way there is no potential danger to the pleura.
To the pleura.
Otherwise,
Just add to it. I used to call the general surgeon for some time because it saves time. But believe me, whenever 2 or 3 punctures I had, she had the punctures. When I did, I never had a puncture because I was more cautious.
Yes.
Very cautious, very chondrium, and it is easy. But I think every ENT surgeon should just a little bit.
Now the rhinoplasty guys are doing it routinely.
Right. Okay.
No,
Fine.
but I may ask, I mean, of course, we can do that. Is there a medical-legal angle to it? Have you explored that medical-legal angle to harvesting the graft?
No, I don't know.
Because
But I mean, see, I have seen my facial-maxillary guy dissecting the fibula and bringing it here.
Okay.
So I think the rib is much more closer to the ear.
Yeah, but I mean, we have a medical legal expert, so Dr. Seemab, I mean, would give his.
Are there rib surgeons? I don't think any surgeon is qualified to harvest.
But like a general surgeon, just like when we are discussing always you have a presence of a neurosurgeon. Just a presence.
I mean, these are things which are related with the specialty, and we should know it out. That may temporis fascia is also close to the brain, so you don't have to do a neurosurgeon for that. But these are simple things. But you are not doing chest surgery, but you are taking a grip from the chest, and which is very much part of it. All these
We look into this. A good point. But I think the rhinoplasty guys are more prolific and more prominent. So maybe they should do it.
So then, after you have put in the basic cartilage framework, at which stage, I mean, after how much time do you do the elevation or lift up the pinna?
So the textbook says 6 months, but that's not what I follow. I like the skin and the framework to remain married for a long time. So the longer it is, the better the vascularity. And my preference is if I have operated the child at 9 or 10, is when they go from 10th to 11th. So 15 to 16 is when I want to do it. So longer, then I encourage them to wait a little longer. But minimum I would wait is 1 year.
1 year. And at that time when you take the extra cartilage, you nest it in the chest only or in the ear?
The first time when we do, we keep it in the subacute pocket. So it's just a 10-minute skin incision and we get it out.
Fine. The next question again, I mean to Dr. Seemab. This is from Dr. Joel Matthew. How can you get a complete PSG with DICE?
It's just a logistical issue. You're doing it intra-op like I showed you.
Not complete is meaning it has a duration.
Yeah.
Yeah, no. These are limitations that we obviously have with the evaluations in a sleep case. You cannot have like a 20,
You can't have a
24
7-hour.
10 hours, 7 hours.
I mean,
So it's going to be a random snapshot. See, any sleep study that we do also, whether it's a level 1 or 3, sleep patterns change every night. So what was there on Monday may not necessarily be the same on Tuesday. But that doesn't mean we sit doing a sleep study every night. Logistically, all sleep evaluations are taken as a random snapshot of your sleep architecture. And that's exactly what we're trying to simulate, because with the dice also, when you're giving the drugs, you're trying to get him down to the lower levels of sleep. And that's what you pick up with the patient. The same thing applies to cine MRI. How do you know at what level of sleep? So these questions will always remain unanswered.
So the
But
saying
sorry,
for this
yeah.
is, you don't have to drink the whole ocean to know how salty,
Salty
it
it
is.
is.
Just a sip of that water is enough to tell you.
Exactly.
Well put.
But then when you're doing a dice, many a times, good number of these patients may be, having maybe, some whiskey before sleeping, or they may be on certain alprazolam drugs. So what do you do about all those things? They may be natural for somebody. I mean, it may be they may be having it every day, na? So I mean,
For a dice, of course, that doesn't work because they're NBM for the procedure. But for a regular sleep study, yes, I tell them that you continue your routine. Because you don't want to disturb sleep that you want to check. So if they are used to their 2 pegs at night, please go ahead, have that. If you're used to your regular alprazolam, fine. Literature wise, yes, there is a query here, but the issue is that if you're not practical about it, you're going to get a disturbed sleep architecture
Yes, it is.
if you disturb that patient, and you're not going to get anywhere.
And ultimately your aim is to treat him in his natural
natural
disorder,
thing. So
Exactly.
that means
Yeah.
he requires a sedative, a drink or whatever. I mean,
Whatever.
along
And
with
that
this.
is going to be his
And-
breathing pattern on an everyday
Everyday
basis, which is
basis.
what you are planning to treat.
Exactly, yeah. Now again to Dr. Ashish, Dr. Karan has asked this question, common complications of atresia surgery.
Well, commonest of course is restenosis. Even world literature says more than 54% is going to close down. To the degree will matter. That's the reason why I'm going away from making the canal which is skin lined. I'm trying to bypass the canal by trying to transmit the sound without this. So I'm trying to put a silicone block, or I'm working with a company to make a Teflon block where the entire need for the canal is gone. That is, I think, what I'm coming to.
Dr. Basir?
I have a question to Ashish.
Yeah.
I have friends in Thailand and Korea, and they are doing a lot of these Medpor with temporal asphyxia, and they say the previous Medpor extraction rate has tremendously come down.
Yeah.
Now, what is your experience in long
I agree with them. I agree with them that as we understand, the critical part of the Medpor success is the TP flap.
Yes.
And I think, so Rainesh is the father of Medpor. His, just one word while drinking coffee is, the flap, the TP flap should flop over the framework. If you stretch the flap, you're compromising the vascularity. So the dimensions become very important. And I think the secret is just there. nothing else.
Do you think in future the Medpor would replace the TPA?
It can, but the only drawback is it has no sensation. So it doesn't feel normal because the skin is grafted after the TP flap. So there is no sensation. The patient doesn't feel a mosquito bite or anything, the temperature. Whereas the rib offers you the local skin, so the temperature, tactile feeling, so you can feel the ear. So I have a little prejudice to the natural feeling. So I use Medpor only until such a time where we can, probably do.
Do you think cartilage
Term
regeneration
called HIM. So the
and nothing
last World Congress
revision surgery starts becoming a very
tight-fisted. They are not opened yet. They're just showing the promise, as we say, show the cleavage and seduce. Nothing beyond that. So they've shown us the cleavage, but we don't know when we see the whole picture.
great. Dr. Basir, can without opening the nose, I mean, can you still correct a caudal dislocation of the septum?
Yes, many times. We don't need to open the nose, the dorsum.
Dorsum.
You have to expose the septum, obviously.
Yeah.
And routine caudal deviation, they are managed by this only. You expose the caudal septum, expose the spine.
Fine.
Do a little bit more dissection. Sometimes you may used to have a very fine cautery because there are a lot of blood vessels over there. So, and that bleeds a lot. So just have a little fine cautery be covered with some insulated material so it doesn't damage the skin. Expose the whole septum from both sides, and you can do it. In fact, why a routine septoplasty? Why should you expose the dorsum? If there is only a caudal deviation, you can easily fix it up.
Okay. And another question from Rajendra Dinesh Kumar to Dr. Basir is, how often does the dorsal hump influence the overall result after correction in terms of aesthetics and functional aspects?
See, here we are talking about two things. One is a hump only, and one thing is that very often there is a hump and deviation. So if there is just aesthetic hump, it doesn't have any functional bearing. But there is a very large number of patients, especially those who are Iranian descent and those who are on this thing where there is a large hump, Kashmiris, they have a large hump along with this thing. So here you need to correct both these things. You have to take care of the hump, you have to take care of the dorsum, and in fact it is good for the patient because you are using expander graft in any case. So the inverted V deformity is very common after the hump removal is taken care at the same sitting.
Dr. Ashish, Dr. Ria has asked this question, how common is combined atresia microtia in India?
How common? No, we just brought it in. So it's been last 2 years that we are doing this, and very successful. So common, I mean every mother, every parent who comes in, he wants the child to have a normal looking ear and a ear which hears. So the need of course is there. It is just that our experience is now allowing us. There's a natural resistance like for every human being to not subject the child to multiple surgical procedures. Of course, if safety demands that, then you do multiple, but if it can be done. Imaging has made a radical difference to our understanding. And I think that has become a preoperative sort of a tool.
Ashish, my question to you, will navigation be helpful in this?
So nerve monitoring is what, if at all.
That is right, but if you have a CT navigation, now here the radiologists are coming into your OT, looking at the film. The way we use navigation in neurosurgery or in FES, would it help in canal cases also? So where you would know how far you have.
So even because you don't need an intra-op that much of a knowledge because he's already done it pre-operatively.
Okay.
So I don't see a value for navigation because except for the facial nerve.
But probably if you have one at your place already, then it should be.
Sure, I mean if you have it, probably and you use it and you tell me whether it makes sense, then I'll go ahead. But there's a lot of virtual on the imaging itself, and we are trying to do measurements, so we already have the map. The only thing is the facial nerve monitor, perhaps when you're doing extensive, this is not really for atresia, for cholesteatoma. When we have cholesteatoma along with this microtia, that's when the nerve monitor, because then you have to drill a lot. You have to bring everything down. So I have had a facial nerve paralysis in a cholesteatoma. Patient had undergone surgery twice. There was actually a salivary fistula, hemifacial microsomia, and I completely missed it, the turn that it took, and I was very confident. In fact, I had to see the film 10 times to realize where the hell I may have damaged it. From then on, that right angle turn from the second genu became an obsession. And therefore now having the round window, every possible landmark telling me how far the facial is how I evolved. I mean every failure teaches you something more.
Yes, but when you see these patients of microtia or something, or I mean, they have many times bilateral involvement, I mean. So you do both at one stage, one sitting?
There's a guy, a friend of mine, Neil in the UK, he does both at the same stage, but these are NHS, medical college, he's got residents, but I think it's cruel. It's to harvest the rib at the same stage from both the sides, although they get pain only for a day or two, but I would not like to harvest ribs. Medpore also because you need the TP flap. You don't have a scar here, but you have a scar on the scalp. I think one at a time. I'm not a multi-procedure person.
A similar question to Dr. Seemab, that with OSA, you may find problems at multi-levels. I mean in the nose, nasopharynx, or even at the larynx. So you prefer to do all of them at one stage, or you would like it to be staged?
That's what I mentioned. Ideally, it all depends on your counseling, the kind of patient that comes. Earlier and generally stationary patients, or stationary meaning easily accessible for follow-up patients, are the kind that you would prefer to do a single level multi-stage. But what's happening is the scenario changes. With medical tourism coming in, you can't expect the guys to keep coming back to you. So if a person from out of town, out of country comes and he's got about 10-15 days, then if everything else is okay in terms of operability, then I would definitely prefer a single stage multi-level at one time, provided of course safety factors kept in concern.
So single stage basically. And provided the nose is not packed or something like
Yeah, nowadays I think
generally.
most of us don't pack the nose. I'm sure. I mean, all of us.
One
are
minute, Dr.
either-
Basir, would you pack the nose? I mean, always?
Not always, but my idea of picking the nose is not for the septum. Like I do for anaplasty, like I pick an marginal incision, I want this skin to be adherent to it. So usually 24 hours I put Morocells. And sometimes I do just put a silicone when for septum, then you don't pick the nose.
For regular
Okay.
nasal work, I think most of us don't seem to pack nowadays much.
I pack the nose for my peace of mind, so that the patient's one drop of blood, they feel it's catastrophic
Yes, in
bleeding.
private
See,
What about
I
Dr.
would like
Liver
to add,
packing?
me and Ashish probably would do these nose cases purely for nasal obstruction. We are not cosmetic surgeons. If it is a genuinely indicated case like a bilateral ethmoidal polyposis or anthraconal polyp or a bad deviation, my patient is already used to a fair bit of nasal obstruction. If my pack gives him mouth breathing for one more day,
Makes no
what is wrong in it?
Right.
If I find somebody struggling to breathe with the pack, it means my indication has gone for a toss. So I pack everybody. It's easy to advise this, but getting this patient with a trickle of blood 2 hours later in the ward and then trying to pack
That is.
is a big news.
Yeah, your indication has gone for a toss, or your morality has gone for a toss?
We call it as a plot case or a site
Yeah,
case.
the only clarification is, I mean, that is isolated nose work, fine. But when you're doing nose
you're doing
plus something else, better not.
Multi-level to better to.
Yeah, better not.
Okay. Dr. Deepak, this is a question.
Can I ask,
Sorry, Ashish.
for these dyes, these people who are, how safe it is? Because these guys are already compromised on their oxygenation,
That's what
Should
I
one be
suffered
careful?
Right in the beginning, I had the first very two, which initially put me off because their airway collapsed and we had difficult ventilating.
Yeah.
So you have to be prepared with everything. They are more prone to collapse.
So it's to be done with a lot of thought.
The anesthetist is your key in a dice. It is not you, because you are doing nothing, just
No,
putting-
so whatever we did, guys, we only did. She would make the face and then send it. That time Ashim was helping us. I was irrelevant, honestly, here.
The use of Dexmed now has made it better,
Made it,
because
yeah.
Propofol a little bit more also can cause an immediate collapse. Dexmed is a gradual
But then that-
onset thing.
That anxiety was too much, so we stopped.
Yeah, basically, Ashish, use of Dexmed, as you said, is basically having a lot of cardiac stabilizing effect, one, and it preserves the respiration, two. So, because of that, Dexmed has made DICE very
But
safe.
yeah,
And now,
put it in
only
one
thing,
simple word,
yeah, it has to be
DICE
given
is
in
a
a drip,
triple
and it has to be
dangerous.
given beforehand. I mean, you cannot give it as a bolus, basically.
Not as a bolus,
You can't give
start
it as a
15,
bolus.
20 minutes, but
Gradually, as a drip.
But
You
the
have to
word
have
of caution is that monitor them for at least a couple of hours, because bradycardia and hypotension is an issue. Not bradycardia, hypotension is an issue with Dexmed.
Yeah. Dr. Deepak, this is a question from home ground. Jay Bharti is asking you. Percentage of patients with vitamin D, B12 deficiencies having vertigo, is supplements enough or do they need anything else?
Honestly, I mean, I've been now doing vitamin D and B12 on many patients, and I find a lot of them showing deficiency. Last 2 years, I have also realized that the laboratories have increased the threshold of the values for the deficiency. I don't know whether it's a cardiology racket.
Like cholesterol.
I don't know this. But all that I can say is a lot of patients who come with anything, nowadays I am finding them having vitamin D deficiency and B12. So I am not sure whether this applies to vertigo also, but it's a general thing. But I am looking at it, I am just looking at it, treating it as well, but no clear-cut statistics as of now. Because my awareness of these two things itself came in the last 1 year. When Naveen and Bhavna Arakkal made me sensitive to this, that some vertigos they recommended B12 estimate and we did find that low. Now whether that is a coexisting factor or a causative thing, right now my knowledge is a big zero.
So it's called as the Friday the 13th syndrome. There are as many bad things that happen on the 12th and the 14th, but Friday the 13th gets blamed.
I think coincidentally, this B12 thing gets incriminated for a lot of issues. You know, even
What time?
the B12 is etiopathologically correlated with restless leg syndrome, which again causes sleep disorders. So, you know, I think somewhere it's a little, maybe overhyped, maybe, we don't know.
I mean it's still at a nascent stage,
Yeah,
maybe
still
5-6
too early
years
to
down
say.
the line.
But I like the company's punchline, nude at noon. Sunbathing, the best treatment for
Yes.
B12.
yeah.
Ashish always makes it interesting. Now, next is to Dr. Baser. This is again from Dinesh Kumar. Scoring of the nasal septum and nasal cartilage memory, can it cause failures?
Yes, he said
Yes,
so.
it is. I think I have practically stopped it. As I say, it may work, it may not work, but unpredictable. You don't know what is going to happen. Just believing that you are scoring and it will turn back, it doesn't. So I practically am not doing
It probably works well if you put in a ethmoidal baton as he puts it along with.
Yes, that is again just scoring and put a button. It works beautifully.
Okay, scoring and
Memory cannot be relied upon.
Especially
What is that Pooja did for the, she said Teflon piston, why crimp, and you know,
Yeah.
the discussion there. I said open a piston, open the loop and keep, every 2 hours go watch. It doesn't close, you have to crimp.
you have to crimp it. Again, Dr. Deepak, recurrent BPPV from Raj Kumar Chennai, from Chennai is asking you what is the cause and what is the best approach?
Recurrent BPPV, the first cause, as I said, is that it has gone into cupulolithiasis rather than canal lithiasis. When the particles are stuck to the cupula, it is much more difficult to dislodge them and reposition them. Second, many times people come with multi-canal BPPVs. They have a dominant right canal and you correct it, and after 2 weeks when you do the test, you find the right thing is gone and he's got a small left BPPV. See, as our numbers have improved, we are seeing variants. And number 3, sometimes for some strange reason, some don't respond to this, but they respond to brand Darrow later.
Okay.
But again, what I said, brand Darrow should come as option number 3,
3.
not a blanket for everybody.
I think the question was what causes BPPV?
recurrent.
What is the cause of it?
Causes, of course,
Recurrent, that was the question.
Recurrent.
Recurrent. Okay.
Why some BPPVs are recurrent?
Okay.
Dr. Baser, Dr. Kapil Saklani's asked you, what do you do in a patient post septoplasty, bilateral inferior turbinectomy having loss of smell after 2 weeks?
Loss of smell. See, there are 2 things to it. In the routine septoplasty, loss of smell, mostly the blood clots deposited in the nose and not so you clean up the nose. But reaching up to that area is like you have gone too far.
You don't know where the nose ends.
I would like to add a line. See, there's something called as a Mosher's line or line of Mosher. If you take the axilla of the superior turbinate and draw a horizontal line from the axilla of the superior turbinate, if you mess up with the mucosa above that, technically somebody can do it, then you can have a loss of sensational smell.
So my one question to Baser, he said he charged $1 more than the New York. Can I know the figure, please? So that I can update.
When the income just came out of income tax people.
Okay, you can whisper in my ear.
The previous question, sometimes recurrent BPPV or patient gets okay, still the vertigo keeps coming in. Just keep vestibular migraine in mind.
Vestibular.
Rarely, yes. Yes.
So, what would be a diagnosis, I mean, for vestibular migraine? Can you just tell us?
Again, it is by omission only. These patients get in severe vertigo, some of them have headache is not mandatory, but the trigger factors are the same. They have fasted or sleep disturbances, exposure to hot sun, and every time you test you don't find this BPPV kind of vertigo or anything.
Do you find phonophobia, photophobia
Yes,
as a
yes,
part
yes,
of it
yes.
actually?
All the other symptoms,
Vestibular symptoms.
except the headache.
Excepting the headache.
So for me, if anti-migraine treatment works, it is migraine. It's the simple way. 5 days and then put them on Cybelium.
Yeah. Another one to you, Deepak, is patient with VBI presenting with vertigo, treatment approach from Dr. Rajendran.
See, again, it is like a transient ischemic attack. So basically you put them on your ecosprin and other things, but the moment it is VBI, I think it goes to the neurologist. You have no business treating it.
No.
The MRI is done, the vascular people get involved, your diagnosis ends there, then you have to pass the buck.
Yeah, Ashish, Rahul Kumar wants to know, are stem cells used to grow cartilage for transplant in pinaplasty?
Not yet, at least in the clinical application. The problem is not about growing the stem cells. It is about how to stop them from growing. Because potentially they are all carcinogenic.
Yes.
So the scientists have found the on button, but not yet the off button. So the science is at that point.
It'll happen like a Pinocchio, basically.
Yes, I mean it's potentially malignant. They'll keep on proliferating.
Right.
So growing them is not a problem.
Right. Dr. Basir, Meenakshi has asked this question. Can we predict pre-operatively how much benefit a patient of septoplasty will get?
Yes, you can do it. In fact, the Cotton's test, I find it very useful. And many people come and they tell you that I lift my nose, it works. It works. I put my tape in the night like this, stretching it up. So the Cotton's test is a very useful tool, a clinical, simple test. It works. But one thing remember, deviation only and nasal obstruction are two different things. Many patients with a deviation, there are no nasal obstruction, and then you don't no business to treat them.
Yeah, because sometimes you find their septum straight, but still, I mean, they're
having obstruction, yes.
having obstruction. So, I mean,
In fact, during our early careers, we would raise down so many septal spurs on the floor. And now we realize the current actually hits the inferior turbinate and goes to the middle meatus.
yeah.
And we were never concentrating on that middle meatal space.
Right.
And many times now a correction of a concha bullosa gives better breathing and airway than a corrected bad septum.
And correcting the
Very bad.
Tell me, these cases, are there like neuropathies of the nose? These people who have patent airways but no, they complain of breathing?
Yes, sometimes
The empty nose syndrome.
yes,
This is
sometimes
neuropathic, no? The
patient comes that they have gone to all the Jaipur to Satish to Jankiram to Deepak and so, and they come in, though I still have obstruction, and I can see right the nasopharynx from the nose. And really it's just the loss of sensation which has gone up, and I can't really do much about it. But empty nose syndrome, we have it now. The treating is by grafting rib in the region of
So
the...
they have emptied the nose and the pockets?
I don't know about the pocket.
So, Dr. Seema, back to you, Dr. Avinash has asked this question. What is the single best diagnostic test for OSA in a rural setup and which is cost effective? Because they were talking so much of the cost. So,
Sleep with the patient.
I think we are all obsessed with the single best.
Yeah.
Somebody asked me, a single, piston length in stapes which you would like to...
See, when you're dealing with a dynamic kind of a problem, there is nothing which is single, there is nothing which is first, there is nothing which is only.
no.
You have to combine it, and if it's a rural setup, I do understand the limitations, but that's why we said there is something which is recommended and there is something which is mandatory. So you do at least a awake FNLP. So that will give you a rough idea as to what kind of issues you all are dealing with, and do a level 3 sleep study. Because one is physiological and anatomical. You just can't say single test.
So you'll have to combine both of them,
You have to.
basically.
Divya, may
Dr.
I
Deep-
ask a question?
Who's there? No, you'll have to write it down over here, no, please. You can go to Dr. Anil Samtani. He'll just. Dr. Deepak, this is from Dwarkanath Reddy.
No.
Hi, sir.
Can we combine
We have to do
Cinnarizine with
application.
beta-histidine?
See, Cinnarizine or what would I say, beta-histine is, a lot of people are not aware, is the reverse of Wali, whom you saw in Ramayana. Wali is a person, if he stood in front of you, he would take half of your energy. Beta-histine is a drug which should be always given in isolation.
Okay.
You combine it with anything, for that matter, the effectivity of betadine comes down by 50% easily. This is something a lot of people are not aware. Second, why should you combine both at all? For the same purpose, isn't it? I would say, when the vertigo is very severe, and I don't mind a little bit of vestibular suppression after I've made my diagnosis, my first preference would be Cinnarizine. A lot of patients complain of drowsiness and things like that. Then maybe I would prefer a beta-histine. But the people who promote beta-histine say it is not a vestibular suppressant. I don't believe in that hogwash. Because we have seen both do the same action. When we do these tests, the nystagmus is suppressed by both. And I feel combining Cinnarizine and beta-histine is one of the most irrational combinations.
Another one to you from Ashok Kumar. How to differentiate between primary BPPV to secondary BPPV of another canal?
No, again, when they are together, fortunately one of them is dominant.
Okay.
But you get a clue that there is one more canal involved in the beginning itself when you do the Dix Hallpike. So what we do is we treat the first one and call them after a week. And invariably we see that this has disappeared and the other one has come up. And patient can realize that there was a vertigo in this position which was severe, which was much lesser on this side. And now this is completely gone. And that's the biggest advantage of EPLES. The patient himself or herself can make out that this is gone. And then 10 days later they find this is gone. The psycho element goes away. So many patients whom we were calling as chronic vertigo, there's nothing called chronic vertigo. Some of them become so paranoid about the next attack, they keep on feeling a small vertigo which is nothing but panic disorder. But now that they know, last week I came, I put my head in this position, the whole thing went spinning. And after all the restrictions, everything, I came back after a week, same position, no giddiness. You can see the relief on their face and the confidence with which they go back. That's the biggest advantage of these maneuvers.
But could it happen that both the ears are equally affected? The Weber's is not getting lateralized to any side.
Extremely rare. It's like bilateral mean ears. To have two vestibules affected equally, I have not seen it so far.
Fine.
There is a subtle difference always.
Subtle difference is there. Dr. Baser, Dr. Avinash has again asked you, what suture material do you use for fixing with the anterior nasal spine and for reinforcing with the ethmoid bone?
Yeah, so I use PDS, but I can realize that PDS sometimes may be difficult to get and it is expensive. So if you don't have a PDS, use a 40 proline for fixing the spine, but not proline in the on the septum. There maybe you have to, if you don't ever get PDS, then probably you have to use Vicryl or something. But for spine, you can use nylon or proline. Proline is better.
So the advantage of PDS is?
PDS is like it has a long absorption time. So it takes about 9 months to 1 year, and by the time that you get a fixation.
So basically that's why you prefer PDS.
Yes, PDS, but not absorbable suture for fixing the spine. Because the Vicryl absorbs and then again you come to back to septum.
Could you use a suture which Dr. Ashish is using? I mean 5-0 steel. No? You can't.
Steel wires, when they come in contact with the skin, so we have to embed them in the cartilage. This very occasionally we'll get extrusion of the steel wires.
You never get extrusion?
We get,
yeah,
so we just have to pull it out sometimes, but we very conscientiously have to embed the wire as much into the cartilage. If it touches the skin, it's likely to extrude in 1 year or 2 years. Extrude means it just starts coming out of the skin. So you just with the artery forceps you have to tug at it and pull it out. There are new titanium wires coming out now from China, tantalum and titanium coming out.
Dr. Bhumkar, we'll just continue. Dr. Pithe, I mean, he has asked a question from imaging. Can one be sure of continuity as well as mobility of ossicular chain?
Continuity yes, mobility no. So that's when your experience comes when you feel the ossicular chain. So, yeah.
Dr. Haldipur from Dr. Vikram Khanna, in labyrinthitis, vestibular neuronitis, for control of acute symptoms, what is the role of cinarizine plus dimenhydrinate?
Fantastic. It's a very good combination. But if you are quite sure about your vestibular neuronitis, don't forget to add the steroid. Because steroid is the one which is going to cure the inflammation. But otherwise, in acute vertigo, and you are dead sure it is vestibular, I think nothing to beat a combination of cinarizine or cinarizine with dimenhydrinate. Fantastic. Like the strike bowler, first 3 days, but try to withdraw it as early as possible because then the rehab starts. Otherwise, my opinion about it is very good. In acute severe vertigo, I would love that. That's why.
In that combination, the strength of cinarizine is 20 milligrams, whereas ordinary cinarizine tablets are 25 milligrams. So whether, because it is combined with dimenhydrinate as an anti-emetic, so are we reducing the dose of cinarizine and combining cinarizine with an anti-emetic?
Too much pharmacology for a surgeon.
No. Even then, this combination works well. But ultimately, if you notice, even if pure cinarizine, as long as you bring down the vertigo, the vomiting has to stop, isn't it? But this combination works well.
The combination
no doubt
works.
About it.
Again, now we come to Dr. Bhumkar. What is the purpose of exposure of the inguinal joint need for medial to lateral approach for atresia by Dr. Avinash?
It is. Sorry, I don't understand the question. But
Me too.
No, probably he means after you thin the plate and blue line the plate.
Okay.
No. Medial to it is a safety. You have to skeletonize the TM joint and you have to skeletonizing.
Okay.
So you cannot approach the antrum the traditional way.
Right.
You cannot go posteriorly. You have to remain more
You can't
anterior.
hit the oscular chain head on with your drill, no?
Okay.
In the last portion you have to come inside out only.
So the tympanic bone is not
As
developed.
they call it
so you
a
approach
soft
it.
entry as we do in cochleostomy or in this thing.
Any of the questions you want to ask each other? I mean,
I asked him about the rhinomanometry.
the
Because
cost.
I bought one and I'm not sure whether my results are right or not. But
You need to hire a person who is dedicated, who can spend time with that.
In fact, the rhinometry
Basically, I
is also
remember
being used in
when
OSC
Dr. Haldipur said that, I mean, what is important in vertigo, 90% it is history, history and history. And one of his earlier meetings where he said that the time that the doctor gives the patient when he starts speaking about vertigo is 18 seconds, I still remember.
The
So it is-
British Medical
it's not-
Journal
Yeah.
has done the study, not only in vertigo, in today's day, any patient goes to any clinician for any complaint, the mean time before the physician butts in is 17 to 18 seconds.
Yeah, 18 seconds is the time that you stop the patient. So you can
So
imagine that how...
if you can allow the patient to speak a couple of minutes more, 60% of them would get better.
so what's your technique of telling him to stop? Or I say open him.
Honestly, I think there should be people who are dedicatedly treating vertigo, because as soon as a patient comes and he said, I got vertigo, I get vertigo. I say,
Until
nothing to
you
get from
can
this
charge
patient.
20,000 rupee consultation fee.
And most of them come with a whole bulk of CT
And
scans
one
and MRI.
line I would like to add.
So it has to be wide.
Most of the physicians become really good and empathic by the age of 55 because generally they would have gone through all these symptoms by that time. Till you get an attack of vertigo, you will speak like a surgeon. The day you get one, and I got one 4 years back, you can see the difference.
That is the secret.
where you are.
Now back to Dr. Seema. Why do 40 to 50% fail up in PAP usage? Dr. Anil Samtani has asked this.
See, yeah, it's more about adjustments to the masks, and it's more about their inability to use it continuously over a period of time. They give up. You know? So there are lots of things now. Of course, if you look at statistics and if you see the figures that have been spent by Resmed and Philips over the past 20 years in terms of research on masks, it's mind-boggling. Billions of dollars, mind-boggling. But eventually what happens is the interface somewhere patients are not comfortable with. The ability to take it out with them wherever they go, they are not comfortable with. So they do lose out on that. And that figure is not something that has been quoted by ENT surgeons. This figure is quoted by the physicians themselves in literature.
No, but now you even find these machines, $3 machines available.
Those are, I think,
Without a mask, without a hose, without anything,
marketing
they
gimmicks.
can just carry it.
You know,
with them.
those mini CPAPs and
Mini
all that have been
CPAPs.
coming up, they are pretty useless. I mean,
They're
this I
useless.
Can I add a couple of
categorically.
points?
Yeah, Deepak.
One is, see, a lot of us are claustrophobic and the masks are not very comfortable. Number two, the dispensing of the CPAP itself, many times done by the technicians and they keep the setting at a, when the physician himself takes personal interest, the conversion rate to masks does improve, at least in those non-claustrophobic patients.
In the initial segment.
Yes.
But again,
But don't you feel most of the time when you advise a PSG or finally they come with the different types of machines which are there, you know, I mean before the report also. So
That's
probably
because that is
it's
company driven.
industry
Company
driven or
driven.
driven.
In fact, that's why I say, and I say this categorically, that all those are purely marketing gimmicks,
Marketing
including these
gimmicks, yeah.
nose strips and all, because if you understand the pathophysiology, how is opening up the alar valve going to improve your airway to that extent? The
In
contribution
fact,
of the alar wall towards the airway is minuscule.
the point of despair in medicine is that we are trying to put in mathematics treating people who are subtly different from each other. You ask Ashish, whatever we believed as gospel truths when we started our STPs, and over 30 years, how our operation becomes customized in each patient as we are doing it.
Now what we trained as a surgeon, now it's a complication. If you mobilize the stapes, it's a complication. You do a stapedectomy, it's a complication today by today's definition. Yeah.
So Deepak, again from Bangalore, just a minute please, we are at different centers, no? It'd be difficult running this. From Bangalore, Dr. Prashant wants to know, when do you consider surgery for Meniere's disease?
That was a point which I missed in my talk. The last 5 years, I have not found a single indication for me to do an endolymphatic sac decompression or a labyrinthectomy and that posterior canal occlusion or that singular neurectomy.
Singular.
These were all being done because of two, lack of proper understanding, number two, lack of patience from the surgeon's side and the patient's side. But again, I believe patients will go along with us if we have the conviction in what we believe.
Okay.
If Dr. Basir feels a certain technique works good for his patient and is convinced, it's very easy to convince the patient. Same with Ashish or same with me. And the last 5 years, and we have a huge vertigo practice now, thanks to these three gentlemen who are very good. And I didn't find a single...
Isn't there a gentle lady also?
Correct.
Okay.
So, I keep forgetting that. So, what I'm trying to say is, imagine I have not found a need for an intratympanic gentamine.
Yes.
Forget going in for surgery. And you know very well that endolymphatic sac decompression done in best hands, after 4 or 5 years again, it does come back. And I remember long back Kirtane sir telling me, because for me vertigo started and ended with him. And he said, just decompressing the sac alone, giving so much relief to the entire thing, is something which was not convincing him as well. I think surgery almost has come down to...
Yeah, Dr. Bumkar, I think we are on the last question now. How do you skeletonize the TM joint and how do you know when to stop?
Color change. All of otology or all surgery is about play of colors. So it starts looking blue-gray, and that's when you stop. It's like even in canalplasty when you do, it's the same. There's nothing different.
Okay. So thank you very much, and we've had
Thank you,
a lovely time. Thank you all over the country. I mean, we've really
one word of praise for you, because everything looks good if the Sutradhar is good.
Yes.
I think you conducted the whole program very well.
Thank you.
I think a big clap for Divya.
Great. Thank you friends. Thank you.
On behalf of Janssen, first of all, thanks to Dr. Divya Prabhat and the entire set of esteemed faculty for giving us a wonderful time today. I think people would not have felt like moving from their chairs. I can tell you that we had more than 400 participants connecting at various places, right from Latur to Kanpur to Dehradun to Surat to Guwahati and many other places across India. We really thank the live audience here as well as Webstream, our partners, and my entire Janssen team, including all the sales teams who